I wanted to provide an introduction to our amazing guest expert today, Dr. Antonis Antoniou, who is professor of cancer risk prediction at Cambridge University. And he is the brains behind the CanRisk program and the lead developer for this program. He is a world expert in statistical modeling techniques for addressing clinical questions and development of risk prediction tools, which are used in clinical practice, including the implementation of Boadicea into CanRisk, which is very user-friendly, as you all will see over the course of this presentation, and characterizing the risks for genetically susceptible individuals, such as those carrying mutations in inherited breast cancer genes. So I wanted to get started with the first case, which is my colleague Katie Lang's case, but I will go ahead and present this because I think Katie had a last-minute conflict. So the reason for the referral here was that the proband's mother had a PALB2 mutation. So the proband is a 29-year-old female negative for the familial mutation. The CanRisk calculation predicted 20% lifetime risk for breast cancer with or without PALB2 being factored in the mother in the calculation input. So here you see the family history, personal and family history. So here we have the 29-year-old who's negative, but then we have a mother with breast cancer at age 50, currently age 60, who was PALB2 positive, and then maternal grandmother with breast cancer at age 40, died at age 46. So again, you see prior slide was PALB2 positivity. So medical management, there was limited data on remaining lifetime risk for breast cancer for women who test negative for familial PALB2 mutation. Again, is this a true negative? And we reached out to Dr. Tishkowitz, who suggested calculating the risk with the CanRisk model. And using this model, her risk was calculated to be 19% lifetime, which you can see here. So with that, I wanted to hand it over to Dr. Antoniou to kind of comment on this case, because again, she's what we would consider a true negative, but still seems to have high breast cancer risk per the models we're running.
Hi, everyone. Hi, Tuya. Thank you for the introduction. So it's a great pleasure to be here. Can you hear me well?
Yes, we can hear you.
Great. So the calculation has been done with CanRisk. So I thought it would be good to clarify a couple of things first in how one uses negative predictive testing in CanRisk, because there's some intricacies there. So the first thing is how one inputs the test in the proband. So this is a test I can, if I understand correctly, for a specific PALB2 mutation which was identified in the family. So I guess because in that context, one would expect that the sensitivity of the mutation testing is 100%, that they either carry the mutation or not. So the way to input that in CanRisk is through what we call kind of in the settings as a direct gene test result, which assumes by definition that the testing sensitivity is 100%. I should say kind of these issues apply only for those who test negative. So the alternative is to use kind of for those who are more adventurous, to use the advanced options and set the sensitivity for the PALB2 testing in the proband to be 100% as opposed to the reduced mutation sensitivity, which you can see at the moment is 92%. So the effect of this, if it's not 100%, basically the model allows for a residual probability that a mutation may have been missed. So that's why kind of it may give kind of still an elevated risk, because they may think that there's a PALB2 mutation in the mother, so there's a possibility that the PALB2 mutation may have been missed unless you input the testing sensitivity to be 100%. So that's why kind of in predictive test negatives, ideally use the direct mutation testing option. And just to give you kind of an explanation why this is the case in Bodicea. So when it comes to Bodicea, which is the underlying model for breast cancer in CanRisk, we assume that the genetic susceptibility is explained by the rare genetic variants in the innate genes, plus there is a residual polygenic component. So all the other genetic effects that are not explained by the rare pathogenic variants. The polygenic component, of course, then is decomposed to polygenic scores and so on, but I will not go through that now. So basically kind of it means that there is a residual component not due to kind of the genes, which kind of explains familial risk. So, and if we go to the next slide to indicate kind of what the implications of this is. So this is a slightly busy slide. So basically what we are doing here is we are estimating the risk for the proband who is 20 years old, assuming that the mother tested positive for a mutation. So like the example where we have a predictive negative test in a way, and then the different graphs are the under different assumptions about the mutation in the mother. So the black curve on the top assumes basically that we don't have any information, that we are predicting the risk on the basis of family history. So as you can see, that's in that case, the risk is over 25%, around 27%. But then if you assume that the mother is PRC1 positive, but the daughter tested negative for the mutation, as you can see, there's a big drop in the risk in that case. It's the red curve. It's only just above the population risk. Then if the mother is PRC2 positive, as you can see, but the daughter is negative for that mutation, is slightly higher. And for PALB2, as you can see, it's slightly above the BRCA2 kind of case. If someone carries, if the mother had one of the moderate risk variants in check to an ATM, but the daughter does not carry that variant, as you can see, the risk is only slightly lower compared to family history alone. So basically, kind of there's a gradient depending on kind of the risk basically conferred by the pathogenic variant. So the highest the risk, kind of the bigger the drop in the risk for predictive test negatives. So you can see kind of that there is a residual risk, basically kind of the more moderate risk variants cannot explain the familial aggregation that we're observing. So there's a residual component that gives rise to this. So I think that's all the slides that we have here. I don't know if anyone else has comments here. Or,
Yeah, I wanted to open up the floor for some comments, and then we're going to Dr. Antoniou is going to give a presentation just to kind of give an overview of CanRisk. Any questions about this specific case? The only thing I would think for this case is we should have set the sensitivity to 100%, right? Like because she was a true negative. And that may have reduced the risk a little bit more.
That's right. That would have reduced the risk a bit. Yeah, they would have reduced the risk lower if that was not the case. Yeah.
Yeah, which I didn't know to do that. So that's very good to know. So we have some questions here. Robin Palmer asked, should one use direct test option for known family mutation for the person that you're calculating the risk for, even if panel is done, and should one put mutation search and absent for all other genes?
That's exactly what you're doing. Assuming that the gene panel test that was done would detect the mutation 100% that was identified in the family, and I assume that that's the case, then that's exactly what one should do.
Okay, no, that's good to know. And then another question. So just to clarify, if there's a known family mutation, the patient is negative, sets the sensitivity to 1 for that gene. So yes, that was my question too. So that's perfect. How do you incorporate higher and lower penetrant variants of CHEK2 and ATM into this model? Love this question because I had that question too.
I think this is one of the case studies that is coming later. I'm happy to answer it now, but when it comes to the pathogenic variants, basically we assume that the risks are equivalent to the risks conferred by truncating variants only. So at the moment, the model is not allowing, for example, if you have a CHEK2 variant which has the risks which is lower than those than the risks conferred by truncating variants. So, or in the case of ATM, for example, there have been some mutations that have been associated with very high risks, very much higher. So in that case, we cannot allow for those in the model at this stage. This is ongoing work, but they're not in the model yet.
Yeah, and I know in the UK, you guys don't test for, or you don't report out the I157T CHEK2 variant, which is a huge problem for us, right? Because here we find that in tumor tests all the time, and it's essentially a SNP. It's 1.3 or so odds ratio. So it doesn't meet the threshold for recommending screening in and of itself. So that's not a mutation we would put into CanRisk from my understanding, right? Because it's going to overestimate your risks. And same thing, I had one of the ATM high risk variant carriers, the 7271C to T, I think it is, whatever that one is. But I didn't run CanRisk because I would underestimate. So we just need to be aware of that, I guess. Until you all figure out how to incorporate it.
Yeah, this is something that we're working on at the moment on including kind of variants which may have different risks. So this is the case with BRCA1 and BRCA2 in particular, kind of the variation with respect to mutation location and so on. This is ongoing methodological work that we are doing at the moment, but they are not in the models yet.
So are you looking at BRCA hypomorphs as well, looking to see how you can refine some of those risks?
Sorry, in terms
so the BRCA, the lower penetrance variants, the hypomorph.
Yes. So this is what we are doing, basically allowing for mutation-specific risks in that case. So we are kind of working on a framework which will allow that methodologically, but of course they are not in the models yet. At this stage, you should only be considering variants which have risks which are equivalent to those conferred by truncating variants.
Okay, that's fascinating. That's fantastic. I have another question. Can someone quickly rerun the model for this patient, resetting the sensitivity level and let us know? I wish I could do that. It's Katie's case, so I don't have it. But you know what we'll do is we will rerun it and send it to the group of attendees so that you have the information, we can all learn from it. It says, another question. I don't think CanRisk includes history of breast biopsy as other models do. Please address.
No, we don't at the moment. It doesn't take previous biopsies into account. It's true.
Yeah, and then Nicoletta's comment, we all agree that PALB2 is a high penetrance gene, which again, I like to think of it the way Mark has voiced in the past, where risk is a continuum. So PALB2 is one of those genes. Yeah, if we're going to have to categorize it, I think most of us think of it as high penetrance, but it's I think risk level in PALB2 is continuous. But Antonis, what are your thoughts?
I think most of the evidence suggests, it was shown by the PALB2 interest group that the risks are 50%, around 50%, the lifetime risks are around 50% or greater. Certainly the relative risks are greater than 3. And some of even the population-based studies, like the Bridges gene panel sequencing studies and the carriers as well, suggested that the risks are high for PALB2 truncating variants. So I would certainly class it as a high risk gene.
And then here's another interesting question. Can you please address CanRisk accuracy for non-Caucasian populations? So people of non-European ancestry.
I will cover that in the presentation on the work that we are doing in customizing this now in the non-European ancestry populations. But at the moment, most of the data that we had came from women of European ancestry, but we hope that there'll be a version released later this year which will address this kind of for African ancestry, kind of Asian ancestry women and so on. So this is kind of our focus at the moment. But I will cover some of those things in the main presentation.
Okay. And here, so Mark Tishkowitz had presented before, and he didn't encourage inputting PRS yet. You agree with that?
I agree with that. Well, as we'll see from validation studies, the model appears to be, I will show later in the presentation that we have done several validation studies that now show at least that the model is providing valid risks. I guess the question is, what do you do after that? In terms of what we need is kind of the studies to inform us about, kind of how it changes clinical management later on, and kind of how it influences the different outcomes, the uptake of different interventions, the psychological well-being of women. So these are the data that we don't have, and there are ongoing studies at the moment that are estimating this. But in terms of the model validity, I would say kind of we do get valid risks on the basis of the polygenic score, or when you include polygenic scores in the models at the moment.
Yeah, and I have a comment here from Mark. Agree to input PRS as part of a clinical study. Yeah, I agree with that. Okay, so I will hand it off to Antonis now to go forward with his presentation.
Thank you very much, Chuyas. So what I'll try to do in the next 15 minutes or so is give an overview of the work that we do as part of the CanRisk program, which aims at personalizing cancer risks for women and men on the basis of the combined effects of different risk factors for the diseases, so genetic, lifestyle, hormonal factors. And this is done in order to facilitate cancer risk stratification at different levels of clinical care. And of course, the aim here is to identify those who will benefit from the available prevention or early detection approaches. So you work on breast, ovarian, and prostate cancer. More recently, the prostate cancer model was published as well. But I'm focusing primarily on the breast and ovarian cancer, which is what's included in the current tool. So what I will do, I will describe kind of the components that go into the risk model. I will describe the implications for cancer risk stratification, the work that we have done in validating the models in independent prospective studies, how we are developing the user-friendly tools to enable healthcare professionals to obtain cancer risks easily. And then I'll finish with a few examples of studies that we are currently doing in order to operationalize the use of kind of personalized risk assessment in clinical practice. And so I'll start with the various components of the model. So as I mentioned, kind of it includes the effects of rare genetic variants, polygenic scores, lifestyle and hormonal risk factors. So if you look at the different components, starting with the rare genetic variants first. So this table summarizes the genes that are included in the models for breast and ovarian cancer. So as you can see, we have the associations of pathogenic variants in 8 genes for breast cancer and 6 genes in the case of ovarian cancer. And there's large overlap in the genes between breast and ovarian cancer. So this slide summarizes the risks that are included in the model for the breast cancer susceptibility genes. So you have the high risk genes, BRCA1 and 2 and PALB2, and then all the other moderate risk genes have similar risks between 20 to 24% by age 80. This is the corresponding figure in the case of the ovarian cancer variants. So you have clearly BRCA1 pathogenic variants which are associated with high risks around 44%, and then a cluster of the RAF51C, D, and BRCA2 genes with risks between 11 to 15%, and then the more moderate risk variants in PALB2 and BRIP1 with risks around 5 to 6%. So following from one of the questions, this data were primarily derived from women kind of in Western Europe, in Western countries from primarily of European ancestry. A lot of the work that we are doing currently is to customize these models to non-European ancestry women. And there are data now available which are showing the fact that the relative risks that are associated with kind of the variants in the various genes are actually very similar across the different ethnic ancestries. Of course, kind of because the baseline risks, the population incidences are different across the different populations, the absolute risks will be different. So although the relative risks are the same, the absolute risks across the different ethnic groups will be different. So this is something that will be in the forthcoming models. So the other genetic component in the models are the polygenic scores, which summarize the combined effects of the common genetic variants that have been identified through genome-wide association studies. So the latest polygenic score is based on the data from the Breast Cancer Association Consortium, or based on 313 SNPs, and which has been validated in a series of prospective studies. So this at the moment explains around 20% of the familial aggregation of breast cancer, and this is considered in the model. So the family history effect is adjusted for the effect of the polygenic score, so that there is no double counting of the effect of the PRS and family history. But again, these data were primarily derived on women of European ancestry. So you see kind of on the top row here is the effect that was estimated from those studies. But we have now data from applying these models, so this polygenic score, to women of non-European ancestry as well. So what we are seeing here is that these polygenic scores are clearly associated with risk in those women as well, but there is an attenuation in the effect sizes. These are the odds ratios for the association per standard deviation increase in the polygenic score. So as you can see, among African ancestry women, this drops down to 1.27, and with a lower area under the curve. So these differences, of course, kind of need to be taken into account when we are inputting the polygenic scores in the models. Another key difference when it comes to the polygenic scores are the distributions of those by ethnic ancestry, and these are data from UK Biobank, which on the top you can see the distributions of the polygenic scores among unaffected and affected women, among European ancestry women, and then you have the polygenic score distributions among African ancestry and Asian ancestry women on the bottom. So what we are seeing here is that the distributions among the African and Asian women, as you can see, are shifted towards having a higher mean compared to the mean seen in European ancestry women. And what this means is that if you actually take cutoffs for the polygenic scores on the basis of the European ancestry distributions, then you may end up overestimating kind of the proportion of men who may fall in the high-risk groups. So this is, again, something that is used now as we customize the models for the non-European ancestry women. One of the key challenges as well when it comes to implementing these polygenic scores in practice is that when you come to design the assays for genotyping the SNPs, we may not necessarily have all the SNPs available because they may not design, but also there are many different methods of developing polygenic scores. So in a recent paper we just published a few weeks ago, we actually show that there is an easy way of incorporating alternative polygenic scores in the model. So basically what one needs to do is to input the parameters that are relevant to the proportion of the familial risk that is explained by the alternative polygenic score. So again, to ensure that there is no double counting of the effect of the PRS in family history and that the model is internally consistent. So, and we show that this can be done easily. All we need to know is just the log relative risk associated with the alternative polygenic score, and then you can get the relevant parameter kind of relative to the parameters for the 313 PRS. So this was done for a number of different polygenic scores now, including those which are used in clinical trials, such as the Wisdom trial in the US, a trial that Mark is leading here in the UK, and also the IMAGE consortium in the US that are using CanRisk as the tool for communicating breast cancer risks. So the models also include a series of lifestyle and hormonal risk factors, so which are summarized here. Again, you can see overlap between the breast and the ovarian cancer risk factors. For breast cancer, we have mammographic density included in the model as well, one of the key risk factors here, which is coded using the BI-RADS classification system. So having all these parameters now, the rare variants, the polygenic scores, the lifestyle hormonal factors. We use information also on tumor pathology, which I don't have time to go through here. Together with family history, we can now obtain more personalized cancer risks for women. And of course, these have implications for risk stratification. So I'll try to demonstrate that with a few examples here. So in this graph here, we are predicting the breast cancer risk by age 80 for a woman in the general population. And the shaded regions in the graphs correspond to the three risk categories as defined by the NICE clinical management guidelines in the UK. So on the basis of the population risk, a woman has a risk of around 12%, as you can see by this, it's shown here by the vertical line. If we then use a model which considers only lifestyle and hormonal risk factors, so we don't consider any of the genetics in CanRisk, then you get this risk distribution here shown by the green curve. And as you can see, there is a small proportion of women here who would be classified on the basis of the lifestyle and hormonal risk factors into the moderate risk category. On the other hand, if you use the polygenic risk scores, then you get the risk distribution shown here in yellow. So which you can see is wider compared to the distribution on the basis of the lifestyle or hormonal risk factors alone. So what this is saying is that the PRS is a better risk stratifier compared to the risk factors. But then risk stratification is maximized when you use the full model, when you include all the information in, and the distribution here is shown by the blue curve here, which as you can see is much wider, such that now you identify around 16% of women who would fall into the moderate or high risk groups. You can do the same for mutation carriers. So this is an example in the case of a CHEK2 pathogenic variant carrier. On average, their risk is around 22%, so they would be classified in the race risk category. But as you can see, if you use a polygenic score on top of the CHEK2 pathogenic variant, you get the distribution shown here in yellow, which is provides wider range of risks, which is wider compared to the lifestyle hormonal risk factors as in the previous graph. But then you maximize again the risk classification if you use a full multifactorial model. And under this, as you can see, around more than 50% of the CHEK2 carriers will be reclassified in either the population risk category or the high risk category, which of course could have implications on how these women are managed in the clinic. So, of course, before using a risk prediction model, it is important that we validate those in independent prospective studies. There have been a few studies now published that have shown the model provides valid risks. I would like to describe a couple of those here. So the latest is based on data from the KARMA mammographic screening cohort from Sweden. So those women over age 40, there are around 66,000 women here. And we have data in this cohort on all the different risk factors that are included in the model, including mammographic density, polygenic scores, and gene panel testing. So we assessed a number of different scenarios here, depending on what information one uses in the model. So the first one is if only family history is considered. And what we are seeing here is the calibration of the model. So on the x-axis, we have the expected risk. On the y-axis, you have the observed risk. And then the women are grouped into deciles of predicted risks, so from low risk to high risk. So what we are saying is that the model here provides well-calibrated risk across the different risk categories and has an area under the curve for discrimination of around 62%. So another way of seeing this is that if you take the 50% of women with the highest predicted risks on the basis of family history alone, in this model, you'll be identifying around 67% of the incident cases that occurred during the follow-up period. If, on the other hand, then you take into account, on top of family history, the lifestyle and hormonal risk factors, mammographic density, and the polygenic score, then you get kind of a much wider distribution, as you can see here, and the model remains still well calibrated across the deciles of predicted risk. There's an increase in the discriminatory ability to around 69% in terms of the area under the curve. And now, if you take the 50% of women who are at highest risk, then those will identify 77% of the incident cases, so a larger proportion. And then if you consider on top of that the gene panel testing information for all the 8 genes in the model, again, kind of the model still remains well calibrated, and you get a small increase in the area under the curve up to around 70%. This small increase is expected because we are dealing with rare genetic variants, of course, here. But you can see kind of an increase in the risk stratifying ability here as well when you include the mutations as well. So the 50% of women at highest risk then will identify 81% of the incident cases that occur during the follow-up period. Another validation study that was done by a different group, not us, it's the UK Generations study. This is a population-based study in the UK. So here the model was assessed for women under and over age 50. So there was information on all risk factors except mammographic density and the rare genetic variants here. So this graph here is showing the calibration among women under age 50, where the area under the curve was close to 70%. So in this study, they assessed also the IBIS, so the Tyrer-Cuzick model that includes the polygenic score. So as you can see, the model had similar discriminatory ability to Bodicea or CanRisk, but what we are seeing is that some over-prediction of risk for those who are predicted to be at higher risk. So there's about a 50% over-prediction of risk in this case. And if you use then, if we restrict to women over age 50, then again, you get kind of good calibration of the model with an area under the curve of around 65%, whereas kind of you can see in the case of the IBIS model, similar area under the curve, but there's this significant over prediction of risk here, kind of among those at high risk by around 70%. And we think that this is happening here because the way that the PRS is included in the model does not adjust for the family history effects. So there is this double counting potentially effect of family history and PRS, which then results in this miscalibration of risks at the extremes of the distribution. So I think kind of most of you will be familiar that this is now incorporated into the, these models are implemented in the CanRisk tool. So this is for healthcare professionals. It has been organized in this accordion style format where the different risk factors are grouped into categories. So the user can input information on the risk factors, including the polygenic scores and including custom polygenic scores as well. They can complete cancer family history, input information on gene panel testing, and the risks then are presented in a number of different formats to ease, to facilitate risk communication. And I'd like to finish here kind of with a couple of examples on how we are now kind of assessing, trying to operationalize this in more routine clinical practice. So this is a study, a randomized controlled trial. It's called Precision HBOG. It's led by Mark Tishkovitz and Gareth Evans here in the UK, together with Alison Kurian in the US, that aims to assess the on how personalized cancer risk from mutation carriers influence decisions. So here, kind of unaffected women with mutations are randomized into an intervention arm, which includes providing multifactorial risk assessment using CanRisk, including polygenic scores, and then they'll be compared against standard care, or where the controls basically receive counseling on the basis of average risks. And then a number of different outcomes are being assessed here, psychosocial, but also the uptake of different interventions. And another trial, which we are starting soon here, again, this is led by Mark Tishkovitz here in the UK. So this now aims to introduce a new multifactorial cancer risk assessment pathway for all the unaffected women who are referred to clinical genetics. So at the moment, those women do not necessarily receive genetic testing because the testing will be targeted at their affected relatives. So what we are doing here is there's an intervention arm where the women will receive G-panel testing, polygenic scores, and multifactorial risk assessment using CanRisk, and then they'll be compared against standard care. And again, a number of different outcomes, as in the previous slides, will be assessed, and there'll be a health economic evaluation of this process as well. So that's all I have. I'd like to thank, of course, these are collaborative studies depending on data from large international consortia. We rely on the study participants, our patient and public partners, and kind of the team in particular at Cambridge and the funders that have supported the work. So thank you.
Thank you. That was really, really wonderful. Here we have still a number of cases to go through, but I'm just going to give you a few of the questions that have come up during your presentation. Your presentation suggests that CanRisk breast ovarian cancer risks are validated if patient is a carrier of a gene mutation, correct? For any gene in CanRisk, that's the question.
Yeah, that's a good question. Unfortunately, I didn't have. Can I share some? Maybe it's better that I explain this because I didn't have time to include it in the presentation. So this is work that is currently under review. So this is a validation of CanRisk now, specifically in BRCA1 and BRCA2 carriers. So this is a cohort of unaffected women with BRCA1 and BRCA2 mutations, and we are validating the model prospectively as well. So here, as you can see, again, you see good calibration of the model in the overall sample of BRCA1 and BRCA2 carriers, but also kind of when you stratify by BRCA1 or BRCA2 mutation status. So I guess, this is what this is saying is that, yeah, the model is validated. We have validation data in BRCA1 and BRCA2 carriers. We don't have specifically cohorts of mutation carriers in the other genes who are unaffected, and we follow them for long periods with kind of enough number of events to assess specifically, say, PALB2 carriers to check 2 carriers. But what we saw in the published study, for example, from the KARMA study, when you take all the mutation carriers together, the model is well calibrated in that set. So
yeah, that's great. Let's go on to the next case because we still have some interesting cases that I think will serve to highlight, the value of CanRisk. The other thing is those clinical trials are fascinating to me, but a lot of us are already using CanRisk in practice because we're trying to individualize risk. So in those trials, they're not using CanRisk in the control arm?
I don't know if Mark is here. Well, at the moment in the UK, at least for the PRS, no, the PRS is not.
Okay, so you're adding PRS, but you would use CanRisk for everyone, wouldn't you? Yeah,
I think it's used, yes.
So it's either really PRS versus no PRS. Mark, is that what
and also I would say the lifestyle and hormonal risk factors are coming in as well because they're not routinely collected at the moment, at least as far as I'm aware in the UK.
We're not universally using CanRisk in the UK. So there's some. So it's basically the study arm, the intervention arm versus standard of care. So some of the standard of care will be include CanRisk, some won't.
Well, because of your guys' program, I'm now asking all these risk factors to get the best scores. Yeah, like it's forcing me.
That's the direction of travel, but we're not all, but that's, and I think, some centers are doing that, others, are not yet. So
right.
So it's really standard care. But as Anthony said, the main difference is PRS versus no PRS.
Okay, got it.
Which is what will make the big difference there. Yeah.
Okay, Mariah, it's all you.
Okay, perfect. So I am a genetic counselor at Vanderbilt, and I'm going to be sharing one of my cases. So my patient was referred due to a family history of cancer, and her mother was found to be positive in CHEK2 for the 1100 del C mutation. So her history is that she is a 21-year-old female, and we did find that she was negative for the familial CHEK2 variant. So this is the family history. My patient's mother was diagnosed with breast cancer for the first time at 31 years old, and then was diagnosed with DCIS in the other breast at age 40. So at the time of her first diagnosis in 2011, she had negative BRCA1 and 2 testing done at Myriad. And then in 2016, she had a 43 gene panel at Invitae that found this CHEK2 mutation. So we can see in the family history, not much stands out. She has some history of melanoma in more distant relatives and some lung cancer in great-grandparents, although those individuals are known to be tobacco users. So given this family history was not very striking for anything else, the patient decided to only proceed with genetic testing for the CHEK2 mutation. And so she was found to be negative. And when we did CanRisk on her breast cancer risk was coming out at 25.6%. And this was done using the method that Dr. Antoniou recommended, doing the direct gene for CHEK2, so that sensitivity was at 100% for the negative. And then for ovarian cancer, she has a 1.8% lifetime risk. So our questions are, what is the true risk based on the family history? And when we compare the CanRisk to the Tyrer-Cuzick, there's a pretty large difference. Tyrer-Cuzick comes up with a 35% lifetime risk. Is the CanRisk model appropriate to use in younger women, or does it inflate the risk estimates? And is there possible PRS interaction with CHEK2?
So keep going. I think Antonis has some slides he had added. So we'll let him comment.
I guess kind of my comments here are, of course, that there's the other cancers in the family which are not considered by the model. So one, I guess, kind of need to be aware of that in case there's something else in that family. When it comes to the negative predictive testing now, so the same principles apply as in the first case. So remember the graph that I had shown that actually kind of for when you have negative predictive testing, when it comes to the moderate risk variants, the risk doesn't drop substantially compared to just using family history alone without considering kind of the negative predictive testing, because a moderate risk variant cannot explain that amount of familial clustering of breast cancer. So the risk will still be elevated here. So personally, I would say that the CanRisk it can be used. I mean, it takes into account the estimated risks from large studies based on women from age 20 to 80. So here, I mean, personally, I would say kind of because Tyrer-Cuzick does not use CHEK2 here it doesn't take into account. So I'm not sure it should be used here. That's where you may get the overestimation, because if you use family, in effect, just in the Tyrer-Cuzick, you are just assuming that there is family history only in the model, which of course kind of can potentially overestimate the risk. I guess I had a question in terms of why do you think it's inflated? Why do you think it's inflated? You say kind of why would the risk be inflated? I guess kind of I think I have a slide later on the validation studies. We see that in women under age 50 and over age 50, the model appears to be well calibrated overall. I guess one issue I should clarify here, of course, we've never done a validation of true negatives. This is, I think we need a lot more data to do that. Usually what we have is a series of individuals who the probe usually tests for the mutations. We don't have a lot of data on their relatives in practice. So as far as how the CHEK2 and the polygenic scores act in the model, yes, they act multiplicatively. And there's a lot of published studies that have shown this now, that kind of the effect of the PRS remains the same in the general population and when acting on CHEK2 background. So this is what I was referring to in terms of the validations in younger women. So on the left hand side is what I've shown earlier in terms of the generation study, the women under age 50. So these are data that on the right hand side is more recent data. The paper is currently kind of been written up, where we have validated the model in women from UK Biobank. So this is more than 200,000 women who have also who have sequencing data. So we have data on all the variants as well. So among those women, we see kind of risks, the model being well calibrated among those under age 50 as well. So I mean, these are the types of data that we have at the moment. So hopefully that answers.
Thank you so much. That's super helpful.
Thank you.
Mariah, this is Georgia, and hi everybody. I'm a little late, and so just trying to get caught up. But Mariah, did you do the I'm going to say the CanRisk study in two ways? Did you add the gene in? Did you do family history alone and then added the gene and then added PRS, or how did you do that comparison in terms of thinking it was inflated versus not? Which is kind of the question that's popped up. What was the risk before testing? So did you learn anything just about the model and doing it stepwise? And Antonis, is that a way for us to better understand what risk is for a specific patient?
Yeah, I guess kind of if we go back to, is it possible to go back to the slide from the previous case? Yeah, so here, so for example, this is exactly kind of what's happening here. So if you were to do just family history, as I think Georgia said, that we now take into account the CHEK2 testing, then you would get a higher risk in principle. So if you put then the negative predictive testing for CHEK2 and the test in the mother, you'll get a slightly lower risk. So that's the pattern that you would expect to see.
I think I was just trying to explain why was Triarcusic elevated comparatively, and because the models are really, I thought, using the same estimates around many of these risk factors. Am I wrong at that?
No, well, there's a difference in how the residual familial risk is explained in Triarcusic. It's not a polygenic component, first of all. But also in this case, kind of, it doesn't take into account that the fact that the CHEK2 doesn't feature in the Triarcusic. So in effect, you are doing, if the models were equivalent, you would be getting the risk that is shown by the black curve here. So on the basis of family history alone. So that's where kind of it would be inflated in that respect, that you are not considering the fact that there is kind of testing for another pathogenic variant, but there is not in that individual. So.
Yeah, I think that's more so what our question was in terms of the inflation, the big difference between the Triarcusic and the CanRisk. But this graph definitely helps explain that a little bit more. I didn't run CanRisk on the patient with just family history, but I'll do that to see what the differences are in that. But again, this data is super helpful in kind of explaining what's going on in these cases.
Okay, so I'm going to go on to the next case because we still have 2 more cases that we really wanted to present to Antonis for his feedback, because again, I think these serve to show us how we should be using the program. Okay, so here's another patient. This patient I saw, 29-year-old with a positive BRIP1 variant, requested guidance on cancer risk management. Mother was positive for CHEK2 and BRIP1, which is why she got tested. So here you see the personal history. Patient, 27-year-old, only positive for BRIP1. What I don't have here is she's negative for CHEK2. Mother, positive for CHEK2 and BRIP1. But then you see here, there's multiple relatives, female relatives with breast cancer, positive for CHEK2, but then a couple are also positive for BRIP1. And then we have this 37-year-old cousin who developed breast cancer, but don't have testing status on her. So again, here is the result. The CHEK2 is actually the Polish founder mutation. Father was a Polish lineage. So it makes sense here. Okay, I'm going to go on in the interest of time. So here is what we got from the CanRisk when I ran it. So proband, reminder, BRIP1 positive, CHEK2 negative. And you can see here that the risk for breast cancer, 18% lifetime risk. She has this cousin with breast cancer at age 37. So even though she didn't meet the 20% threshold, I did send her or refer her to the high-risk breast clinic for consideration of screening. And then mother's risk, what we see here is much higher, but she is, CHEK2 positive as well. And then we have ovarian cancer risk. This was really for the patient. So lifetime risk or age, risk to age 80 was 5.6%. And mothers, it wasn't generated because she had a BSO already. So again, thoughts were patient's CHEK2 negative, but she has this cousin with breast cancer at age 37. So is screening at a younger age with MRI appropriate? So it was a balancing act. Again, this patient is very proactive. So I did refer her to the breast clinic for a discussion. And, as a clinical team, we thought with this early onset breast cancer in the cousin, it was reasonable. Antonis, I don't know if you want to comment on your...
So I guess one question is why didn't you take, because CanRisk can't take into account cancers in cousins, so you can input an arbitrary size pedigree in, so the cancer in the cousin can be added if
I did. This one was a complicated. I'll go back and check it. Okay. I did, and it still gave me this, but it's just nerve-wracking, right? Because you have this cousin untested. We live in a litigious society, so
yeah, it's a distant relative anyway. It may not affect the risks that much in that case. I guess the point that I wanted to make here in terms of the CHEK2, do we know that this variant has risks which are equivalent to the truncating variants? I was not sure here. In that case, given the discussion that we had earlier, we need to be aware if the risk is not similar to that.
Good point. I didn't check that.
So that's a couple of studies that I've looked at. They didn't report. There were not enough data to report the risk. So I don't know. But it was only done superficially. So maybe it's something that you may want to look at.
So should we not be running it for non-truncating mutations? I wonder if that's kind of what we should have in our heads.
Well, it will give you it. I mean, it's an upper bound in that case.
Yeah.
Of, in that, if the non-truncating variants are having relative risks which are lower, then of course, the risk for those carriers will be lower compared to what CanRisk gives you.
Overestimating risks. Yeah. No, you're right.
I guess the other point is that just to keep in mind that the BRIP1, of course, is only associated with ovarian cancer in the model, so it's not taken into account in the breast cancer risk assessment, and also kind of ensuring that the direct mutation testing kind of is has this 100% sensitivity in this case. I think when I saw the report, this may not have been the case, but
it wasn't, because I didn't know to run it that way, so I have learned. In future, that is what I'm going to do. I'm going to just, I know we have very limited time, but let me just, the next case is also very interesting, and I'll go through it super quick. So visit prompted by patient planning to have a hysterectomy and surgery for pelvic pain and endometriosis, as well as option for preventive bilateral salpingo-oophorectomy. So she's a 33-year-old female with no personal history of cancer and a family history of breast cancers and a pathogenic BRCA1 variant identified about 10 years ago. And the mammogram most recently performed in January of 2022, I had her send it to me afterwards and showed dense breasts, which she had reported to me, but it was level C on in CanRisk, so it was heterogeneously dense. No history of MRI. She had a laparoscopic ovarian cystectomy. So here's a family history. Patient is here we go. Patient is 33-year-old, BRCA positive. Mother had breast cancer at age 45. And then it's coming from the paternal lineage, as you can see here. And here is the mutation. So here is the risk that I got. The breast cancer risk lifetime was 80% of interest. I actually ran it with the C category for dense breasts and D, because at the time I saw the patient, I didn't know how dense her breasts were. It was C afterwards, so it's 80%. But just for everyone to know, the risk went up to, I think it was 87 or 89% when I had the highest category of dense breasts in here. So it definitely made a pretty big difference. And then ovarian cancer risk, like you can see here, up to, what is it here? 25%. And note what is being calculated, I think everyone knows this already, is remaining lifetime risk. For the proband's mother, I just wanted to show this because I calculated it for the mom as well. And these risks, as reflected in CanRisk, are like once you've had a breast cancer diagnosis, it's for contralateral breast cancer only, not a new primary cancer in the same or ipsilateral breast. And then we have ovarian cancer risk for the mom as well. So this was the remaining lifetime risk for breast cancer in the mother, which again, I thought was kind of high, it was 40%. But that makes sense because she had breast cancer at a relatively young age. So discussion items, medical management, prophylactic BSO, recommend age 35 to 40 in BRCA1 carriers. Even though she's a little younger, we thought it was reasonable for her to proceed because she's already made plans for a total abdominal hysterectomy for other reasons. So I referred her to Gynonc to discuss next steps. And again, she was someone that was identified 10 years ago, but she hadn't had breast MRIs. So again, she's getting hooked into getting that care. And for the mother, as I mentioned already, the contralateral breast cancer risk. So Antonis, I don't know if you want to comment on the contralateral breast cancer risk here.
So I wanted to clarify one important issue, because actually this is a frequent question that we get through the help desk as well, how one interprets the contralateral breast cancer risks. So what CanRisk is doing is producing model-based predictions. So basically, what that means is that the increased contralateral breast cancer risk is entirely due to how the factors that we take into account in the model. So the rare variants, polygenic scores, if you have those, the family history, or the lifestyle and hormonal risk factors. So Tuya, you may want to press to make the whole slide appear. I think I didn't realize that there was animations here. So what this means then is that when we're calculating the contralateral breast cancer incidence, basically what we do, we have only 50% of the overall breast cancer incidence. So incidence that is applicable for contralateral breast cancer is about half of the total incidence because there's only one breast at risk. So what CanRisk is doing, there are not estimates of contralateral breast cancer from studies that have been published. However, it seems that it's doing the right thing, but what is important to take into account is that there is no effects of treatment taken into account, so of the first breast cancer. So for example, if the cancer if there was treated with hormonal therapy or chemotherapy, which are known to decrease the risks, you need to take those into account. So you need to reduce those risks that CanRisk is doing. The same with pathology. So both treatment and tumor pathology influence the contralateral breast cancer risk, but at the moment they are not considered in the risk assessment. So you need to be aware on how to interpret those risks. So treat those as upper bounds rather than the actual risk. So for example, an ER-positive breast cancer, primary breast cancer treated with hormonal therapy would reduce the risk substantially of contralateral breast cancer. So it's important that this is considered here. I guess a couple of other comments that I wanted to make with you mentioned that you took densities into account for the proband for the breast cancer risk. That's why you see that to be quite high. There is a strong family history as well. And the ovarian cancer risk is it may seem lower at first glance compared to the average breast cancer, ovarian cancer risk for BRCA1 carriers. But I think in this case, there was long-term use of oral contraceptives, which was in the highest risk category, which reduces the ovarian cancer risk a lot. So that's why it's lower than the 40% average risk in that case.
Okay, and we have some questions here. So for this case, would you rerun CanRisk to reflect her upcoming BSO that would reduce her breast cancer risk? It's a good point.
Yeah. The only problem is that we don't take into account the risk reduction in breast cancer risk from the bilateral salpingo-oophorectomy, but also most of the latest data, at least for BSO, suggests that actually there's not much evidence of a risk reduction in BRCA1 carriers. There's a delayed effect in BRCA2 carriers, but not the effect in BRCA1 carriers doesn't seem to be certain there. So that's something to keep in mind.
Okay, and then here's this is a great question. As patient ages and breasts become more fatty, how often should CanRisk be recalculated?
Well, yeah, that's a good question. It's something that we are trying to see as well as part of. There's a lot of studies currently ongoing, trying to see, for example, how many times one needs to be running these assessments and so on. As part of large microsimulation studies, which take into account the changes in density as well. So, yeah, I'm afraid I don't have an answer here, but it's something that it's a very good question.
Yeah. And then I have a comment from Talia Donnenberg, CHEK2 phenotypes among frequent CHEK2 variants. So that was just published in JAMA in September.
Okay. Yeah.
And then here, how long does it take GCs to run CanRisk?
If you have the data, it's very, I guess, it's easy. we understand the issue is inputting the data into CanRisk, which is could be time consuming. So this is something that we have identified in studies that we've done in terms of trying to identify the barriers in kind of for more widespread use. So one thing that we are doing, what we have done is actually developed a new patient-facing tool, which would allow the healthcare professional to send a link via CanRisk to the patient and there's a mobile app which enables them to enter the information in, and then once they complete the information, it goes back to the healthcare professional to complete the risk assessment. So this is currently under testing and it will be used in the trials that I mentioned earlier, but hopefully kind of eventually we can make that available. But also if you are collecting your data as part of a different tool, it may be possible to export those data into the CanRisk format and then just upload that file. So
yeah, so I wanted to just Emily commented, maybe takes me 10 minutes. Family history takes the longest part, which we all know. And then this is true. So with the CanRisk interface, you all have made the code available, right? So there's many ways of doing it. You can either build it within your own system, or you can import the data into CanRisk, because I know Mark has mentioned he uses phenotypes in clinic, and that program can then interface with CanRisk to export the family history. So there are solutions to be able to get that data in depending on what your health system is using. So, you all have made it, given us a lot of options to be able to use the program. And then Talia's comment is faster as more frequently used was Robin's comment. Talia, we are pressured to see more patients with less time for visit. That is true. But again, I think with CanRisk, there are opportunities to be able to save time depending on how you're getting the data. So again, there are some creative solutions that I think are available to us. Another comment, do you plan to integrate CanRisk with any of the pedigree drawing software tools such as Volpara /CRA? I don't know which ones those are, but Antonis, you can address that.
I guess kind of those may be commercial software, so I don't know what they are doing. I guess it's up to them to integrate CanRisk in it, not us. I guess kind of we have, what I would say though is that in terms of integrating Volpara, incorporating the Volpara system for measuring density into the model. So we have completed now kind of a study where we have actually kind of added Volpara and other kind of automated measures of measuring a density. So we hope we're writing the paper now. So in due course, we'll add options to adding on the tool Volpara as well, measure density in CanRisk.
Okay, and then Talia's comment, we are switching to genomics module in EPIC. But again, as we all know, EPIC does not collect family history per what we would need to generate, which is a little bit of a frustration, I think, for all of us. I know Georgia is working at our institution to try and fix that, but there isn't necessarily an easy fix to that.
It's actually a two-pronged problem because you have to put the data in the same, how should I say, the same fields that are correct, that would be exported to a program that would do the analysis, and then you need to bring it back in. And right now, EPIC doesn't even talk well with the individual person's disease list. So there's a lot of work that has to be done on the EPIC collection. And you have to put it in by hand now, which is also kind of stops people in EPIC.
Yeah, and what I wanted to comment is Antonis has given us an overview of CanRisk, but hopefully, if there's interest, which I think there would be, we can ask him if, at some point in time to come back and just show how to use the program, which I think would be of really high interest. I've learned a lot as I've started using the program, but just things like being able to save the data in my own files and to re-import it if I want to revise my risk estimates, or, you know, if you want to generate like risks in a daughter, but then in a mother, there are ways of doing that, but then you have to save your file before you generate the risks in the mother, because the data will get erased. So there are some really fantastic features in CanRisk that I've only learned as I've used it. And, you know, Mark Tishkowitz has been a tremendous asset, because every time I am not able to do something, he tells me how I'm supposed to do it. So
I should say, if you go to the last slide, Tuya, I have I think it's the.
oh yes, let me,
Yeah.
yes.
I should say, so we are here for anyone who wants to ask any questions. So there is you can use the feature on CanRisk to add any question you have. We have a team here who we try to respond as soon as we can. So, or email us at this web address here. So we always like to hear from users, and you know, kind of if you have any problems, always help. And there is a help desk. There's an FAQ section. So if you So we try to put those on the knowledge base. So kind of if you search for any question you may have, someone may have already asked that question, and you may have an answer there as well. So. And
do you have a YouTube tutorial that already exists? That's another question in the chat.
Well, there are links on the two, yes, because we had to do that for the paper, for the technical paper that was published. There are, if you go on the CanRisk website, there are some tutorials that you can use, you can view.
Okay. Perfect. Well, I apologize to everyone for going a little bit later, but again, many, many thanks to Antonis for this outstanding and high interest
Yes, thank you.
which was I can tell you a lot of people joined. So actually here, we can use CanRisk. One last question. We can use, this is from Anar Saju, who I know from years ago, who is now in the UK. We use CanRisk for certain cases and have departmental guidelines for when, 10 to 20 minutes, and we send a cancer queue with the relevant questions to these patients. So again, I do think people have used creative ways to be able to populate the information, which again, I can tell you we are doing as well. So with that, we have an exciting lineup for upcoming case conferences as well. I'll touch base with Antonis behind the scenes to see if at some point he can come back and give us a how-to sort of tutorial on how to use CanRisk. But thank you everyone for attending. Big thank you to Antonis for presenting, and we'll see you soon. Bye.